Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Phase 2-3 study of rituximab plus cyclophosphamide, doxorubicin, vincristine, and prednisolone, R-CHOP21, versus 2-week R-CHOP, R-CHOP14, for untreated indolent B-cell non-Hodgkin lymphoma, Japan Clinical Oncology Group 0203 trial, by Takashi Watanabe et al. This podcast is entitled R-CHOP Chemotherapy as Upfront Treatment for Advanced Stage Follicular Non-Hodgkin Lymphoma. My name is Jonathan Friedberg, and I am Professor of Medicine and Chief Hematology Oncology Division at the University of Rochester in Rochester, New York. My oncologic specialty is lymphoma clinical research and novel drug development. Multiple retrospective cohort analyses suggest profound improvement in overall survival of patients with follicular lymphoma over the past decade, almost certainly due to the incorporation of rituximab into standard treatment regimens. Despite these improvements, however, it is felt that for the majority of patients with follicular lymphoma, the disease is not curable with standard approaches, and new approaches are needed. Because of this, heterogeneous approaches are used as treatment of both de novo and relapse disease. The National Lymphocare Study, a disease-specific registry in the United States which enrolled over 2,700 patients between 2004 and 2007, emphasized this heterogeneous approach and showed that observation, or watch and wait, rituximab as a single agent, and rituximab in combination with chemotherapy are all used in the treatment approach for this disease. At least 4 randomized studies have determined that the addition of rituximab to chemotherapy in both upfront and relapse settings in follicular lymphoma results in higher CR rates, longer remission durations, and even may impact overall survival. Therefore, whenever chemotherapy is used in this disease, it should be combined with rituximab. Although numerous regimens have been studied, including RCVP, R-CHOP, and fludarabine-containing regimens, the most commonly utilized regimen in the United States has been R-CHOP, based initially on a single Phase 2 study demonstrating very prolonged progression-free survival with this reasonably well-tolerated regimen familiar to most oncologists treating patients with lymphoma. In this background, Watanabe and colleagues in Japan conducted a Phase 2-3 trial comparing R-CHOP given at a 21-day interval with R-CHOP given at a 14-day interval for patients with newly diagnosed follicular lymphoma. Studies from Germany in diffuse large B-cell lymphoma, as opposed to follicular lymphoma, have indicated that dose-dense CHOP, given 14 days, appears to be superior to standard CHOP and may be better tolerated when rituximab is not included in the treatment. However, 2 subsequent randomized trials from France and the UK comparing R-CHOP14 to R-CHOP21 in diffuse large B-cell lymphoma have failed to demonstrate any significant differences between the 2 arms in preliminary analyses. In the current study under discussion, a total of 300 patients were enrolled from 44 institutions between September 2002 and February 2007. Eligible patients had advanced stage follicular lymphoma, grade 1, 2, or 3, reasonable performance status, and were under age 70. Patients with history of hepatitis B and C were excluded. Importantly, a requirement for therapeutic intervention was not well defined, and consequently, some of the patients enrolled were treated immediately after diagnosis without watchful waiting. This differs from some other recent European trials in follicular lymphoma, where an indication for therapy is required. The median age of the patients was 55 years. Initially, due to a Japanese policy, patients only received 4 doses of rituximab with R-CHOP treatment, but the majority of enrolled patients received rituximab with every R-CHOP cycle. R-CHOP 14 included G-CSF administered daily for a period of 6 days, starting on day 8 and ending 2 days before CHOP of the subsequent cycle. Primary endpoint of the Phase 2 component was CR rate, and primary endpoint of the entire Phase 3 study was progression-free survival at 3 years. The authors had initially hoped to show an improvement in 3-year progression-free survival in the R-CHOP 14 arm from 50% with R-CHOP 21 to 65% with R-CHOP 14. After an interim analysis, the sample size was increased to provide power to show a 12% difference between arms. With prolonged follow-up, the CR rates and overall response rates were not different between the 2 arms. At over 5 years median follow-up, 82 R-CHOP 21 and 78 R-CHOP 14 patients had a documented progression, and 2 patients from each treatment arm died before progression. The 3- and 6-year progression-free survival rates were similar between the 2 arms. At 6 years, 41% in R-CHOP 21 and 43% of patients in R-CHOP 14 groups remained progression-free. Overall survival was similar, and there was no subgroup who appeared to benefit from the intensified treatment, including high-risk patients defined by follicular prognostic index and patients with grade 3 histology. Toxicities overall were similar between the 2 groups. Grade 4 neutropenia and grade 3 infection were encountered more frequently during R-CHOP 21 than during R-CHOP 14, as G-CSF was mandated in the latter group. There was more neuropathy seen in R-CHOP 14. This well-conducted study has many lessons, and our colleagues from Japan should be congratulated on a well-done clinical trial. First, the outcome of patients with follicular lymphoma treated with R-CHOP is extremely favorable, and it is challenging to improve upon a therapy where over 40% of patients remain in remission 6 years after treatment. The recently published PRIMA study, which randomized patients to rituximab maintenance versus observation after induction treatment for follicular lymphoma, where most patients had received R-CHOP, demonstrated significantly improved progression-free survival with rituximab maintenance. Indeed, if progression-free survival is a primary endpoint, it is likely that future studies will need to include rituximab maintenance in the control arm. Second, similar to the experience in diffuse large B-cell lymphoma, there does not appear to be any benefit to the dose intensification of CHOP chemotherapy when rituximab is included in the induction regimen. The tremendous impact of rituximab appears to overwhelm any apparent benefit of dose intensification as far as both CR and PFS rates. Third, CR does not appear to be an important endpoint in follicular lymphoma. The very definition of CR has evolved. Current response criteria require a PET scan, and some have suggested comprehensive marrow evaluations with PCR or flow cytometry. Particularly in an era where we know maintenance therapy continues to provide benefit, this study and others emphasize that PFS remains the most robust surrogate endpoint of clinical benefit for a given regimen in this disease. So where do we go from here? I think it is clear that dose intensification questions have no further place in follicular lymphoma. In fact, preliminary results of a randomized trial comparing bendamustine rituximab to R-CHOP 21 in patients with follicular lymphoma requiring therapy suggest lower toxicity and prolonged PFS in the bendamustine arm, which is administered on a 28-day schedule. To further improve on the already favorable results in follicular lymphoma, we need to incorporate novel agents as upfront therapy and in the maintenance setting, and choose subgroups of patients to study that may benefit from a specific therapeutic intervention. Currently, the ECOG group is utilizing bendamustine rituximab as the platform for follicular lymphoma studies and evaluating the addition of bortezomib to induction and the addition of lenalidomide as maintenance. Other promising agents include inhibitors of BTK and PI3 kinase, both members of the B-cell receptor pathway, and BH3 mimetic drugs, which block BCL2. Ongoing studies are evaluating these agents in combination with chemotherapy and rituximab. For now, if R-CHOP is chosen as upfront therapy for follicular lymphoma, the current study suggests that either a 14-day or 21-day intervals have excellent similar outcome. As a 21-day schedule has been the United States standard in diffuse large B-cell lymphoma, there appears to be no indication to change this approach. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.